Good afternoon. This is Dr. Garias, Stratford University, and this is MED110 Anatomy and Physiology 1. The best way to look at this is to not only follow along with your book, but kindly upload the Moodle notes entitled, regarding the respiratory system. I'm just pretty much going to briefly go over this. This will be relatively quick. And yes, you will be responsible for this material for next week's final examination. So, let's start by talking about, Let's start by talking about the functions of the entire respiratory system, and then we're going to talk about its separate little parts. If you go on page 855, you will see the meaning of the word respiration. Now, we've been talking about that since the heart. Remember that respiration comes in various forms, but it is all the same thing. It is the trading of oxygen, the good stuff, the fuel, the thing that we need, for the waste product, which is carbon dioxide. So, respiration can mean that exchange, and it also can mean the exchange of ventilation. Because when you're thinking about it, when you're ventilating your air in your lungs, you're sucking in air that has some oxygen in it, right? Roughly 20-21%. And then you're expelling the waste product, which is carbon dioxide. Okay? So know the difference between ventilation, which is moving air into and out of your lungs, and respiration, which is the gas exchange. Respiration can occur in the macroscopic level, as in ventilation. It can occur in the microscopic level, in between your blood vessels and in between your other organs, as we demonstrated when we talked about it in the circulatory system. Now, what are the functions? First one, on 855, we just talked about gas exchange. Number two, you need air, you need ventilation to speak, sound production, communication. You also need it for number three, sense of smell. You cannot try holding your breath and you won't be able to smell anything. It's one of those things where it requires more than one system to be at play. Okay, so you don't have the sensation of smell, which is part of your special senses, which we'll be going over in Anatomy and Physiology 2. There's also a protective function coming in the form of mucus. Mucus keeps your inner surfaces moist for optimizing gas exchange. Gas exchange requires moist material. In the summertime, when it's really, really hot, especially if you're in a desert area like New Mexico or Arizona, it's really, really hard to breathe in those atmospheres because it's really dry. Your respiratory system needs to be a little bit on the moist side. Again, not wet like pneumonia, but not dry like like a desert. Again, back to the requirements of the human body is always about being in the middle. And mucus, the mucus lining of our respiratory tract, tries to keep us in the middle. The other protective function is immune system. There are macrophages in the lungs. The lungs and the mucus and your nose serves as a filtering mechanism. That's why when you blew out, the colloquial term is snot or boogers. That's all the dirt and bacteria and viruses get trapped in there, and that's why I'm constantly telling my children to always blow their nose instead of keeping it in, because your body's going to want to get it out there, right? For example, you got a lot of dust in there. That's why you sneeze. Your respiratory system traps a lot of this material, and then has a reflex to make you do what? Get rid of it. Now, the second I start talking about sniffles, I get sniffles. Interesting. Okay, let's look at some pictures and the components of the system itself. Let's see if the computer's cooperating with us. Computer systems, of course, on a snowy day, they're down. Okay. Now, those are the generalized components of your respiratory system. We have here. Let's see, maybe I might have to even make it a little bigger. Okay. Nasal cavity, remember the hard palate right here. So your nasal cavity, they have 3 passageways, right? And that's also why, you know, if somebody makes you laugh, you see how it's connected to your pharynx? If somebody makes you laugh, sometimes, you know, your milk will come out of your nose. You could see here easily why. You could see that all of this is connected. Okay? Of course, your nostrils, also known as your nares, N-A-R-E-S. Okay? And then, of course, your pharynx. And remember, we talked about the epiglottis, and it covers the larynx, and the larynx to our trachea, from our trachea into our lungs. And we saw all of that macroscopically, gross anatomy-wise, in our laboratory when we cut up the pig. We saw all of those structures. Okay? Now, these structures, they have a delineated upper respiratory tract and lower respiratory tract. Maybe you guys have got a doctor's note. So you have any problems above the level of the trachea, so it's from this point on up, that is an upper respiratory tract infection. So let's say, for example, your nose, you get the sniffles, you get a little bit of a head cold, okay, and you can have rhinitis, R-H-I-N-I-T-I-S, itis, inflammation or infection of my nose. Okay, it could be allergic, it could be bacterial, or it could be viral. But that's the problem, that's what? With my nose up here. You'll also see like some spaces in the bones up here. Those are your sinuses. Okay? Your sinuses, they can also, they're supposed to be empty. Just like a speaker, the inside of a speaker is empty. That's why when you have sinusitis, your sinuses get all filled up with phlegm or water and other bacteria and those kind of things, then you'll notice that your head will feel heavy, you'll have a hard time hearing yourself, or your voice will sound funny to yourself, because your speaker, which is part and parcel, because remember, what is the sound production? The larynx, which is your voice box, pharynx, which is your throat. So you can have another upper respiratory tract infection called pharyngitis, which is your typical sore throat. You can have an upper respiratory tract infection, laryngitis, and you will have aphonia, or a no or not speaking. Because remember, if your voice box gets all stuffed up, especially if your vocal cords, and your vocal cords are like a guitar string. You know, if the vocal cord is nice and clear and thin, right? Yeah, just like a guitar string. When you hit that guitar string, you'll hear music. But just like a guitar string, if I put my hand over it and I muffle it, of course, the voice and the guitar string are both kind of like the same thing. They will be muffled. And that's where you have that aphonia. That's when you lose your voice. So those items are upper respiratory tract infections. A URTI, you should really not go to the hospital. You actually really, because, and most of the time it's viral, which means that it's self-limiting. When a disease state is self-limiting, that means it takes care by itself. 7 to 10 days, it just goes away. Okay? So rhinitis, pharyngitis, laryngitis, in general, upper respiratory tract infections aren't dangerous. But let's now talk about some dangerous situations. Those are lower respiratory tract. That's everything from here on down. Now, the lower respiratory tract is far more dangerous. Your trachea, if that swells up, if that closes up, tracheitis, you have a problem. That means no air will be coming to your lungs. How about if your lungs are in damage? Well, the deeper you go, remember we talked about, the deeper you go into the human body, the more delicate the items are. And of course, any itis, functio lesa, right, loss of function, any loss of function of either one or both of your lungs is very, very dangerous. Okay? Now you will, let's now go to, let's see, I'm looking at my notes. Item number 3, we now know the difference between our upper respiratory tract and our lower respiratory tract. Now we know some medical terms, itis terms, pharyngitis, laryngitis, rhinitis, which is inflammation, infection of your nose or your nasal cavities. So let's now go to the trachea. Let's see if there's a prettier picture. Bear with me because the internet is on the fritz, and worst comes to worst, I'll just talk you through it. Come on. Wow. Okay, I'll talk you through it. Oh, here we go. Here's another version of it, and you can see some of the sinuses here, right? There's spaces. Your bones are not solid. They're hollow, and they have things in it. And those of you who had sinusitis or allergic rhinitis, see, here's another sinus, here's another sinus. So they're holes in your skull. They're hollow rooms in your skull. They should have air in them, but every once in a while, mucus gets in there, bacteria, virus gets in there. Another beautiful picture of your nasopharynx, oropharynx, laryngopharynx. Okay? These are all upper respiratory tract locations and items. Okay, let's look at that a little bit. That's your voice box, also known as your larynx. You can see that it is colored the same way as bone, and guess what? All of that is cartilage. It is beautiful because it has the strength of bone, but it's flexible. Okay? It needs to be flexible because guess what's behind it? The esophagus. So if you eat something really big, you know, and that's why the trachea, well, here's a little bit the epiglottis, and we saw that in the vocal cords. You can see the vocal cords. You can pretty much understand if those things get thick, how does sound production work? Not very well. I'm trying to get to our trachea. And you can see here how their muscles, you know, just like you ever play with a guitar string. If the guitar string gets shorter and shorter and shorter, it'll make a higher pitch. When it gets longer, because when the string gets longer, it'll make a lower pitch. Your muscles control your vocal cords in the same manner. Trying to get to my trachea. There you go. This is all cartilage, and you'll start noticing that when you're closer to the top, closer to the larynx, and starting at the larynx, the amount of cartilage is abundant. The trachea is filled with C-shaped cartilage, and you could see here that it's C-shaped. So it's C in the front, but the back has to be what? The back has to be flexible, because behind the trachea is your esophagus, and sometimes food goes down there. And again, goes to show you. And he goes, you should not be talking while you're eating, because your body doesn't appreciate that, because both tubes they'll tend to occupy the same space. Another thing you'll start noticing is that there's a theme of this cartilage, protective cartilage. Now, the cartilage makes sure that the tube stays open. Okay? Once this tube starts closing up, or if there's an obstruction with a foreign body or something like that, then no air gets to where it has to go there's no gas exchange, and then you die. Starts at the trachea. Then the main branching point is called your carina, and then they branch off into all these little branches called bronchi. Bronchi is the plural, bronchus is the singular. So know the carinae, know your trachea or windpipe, and when it starts branching off, you have a main stem bronchus or a main stem bronchi. There's more than one, and then it goes to lobar and then segmental. So it gets smaller and smaller and smaller because remember, gas exchange must occur at the smaller levels, must occur at the level of the capillary. We already discussed that during lab. We already discussed that during the chapter with our cardiovascular system. Okay? So I could ask you what kind of cartilage, C-shaped, where does the cartilage start up? It starts up at the level of your thyroid and cricoid cartilage, in the level of your larynx or voice box, and it goes all the way down. And it gets smaller and smaller and lesser. Now, what gets more and more as the deeper you go? The deeper you go, you have more and more smooth muscle. Now, remember we briefly talked about that in lab, we briefly talked about that when we were talking about muscle, but smooth muscle you can't control. You can control your breathing to a certain extent, but you cannot really control you opening and closing your bronchial tubes, or the tubes that are inside your lungs. Just like your heart, you can't really control you can try, but there are some effects, but overall, you really have no real control of your heart or lungs, and and your lungs, and specifically also your digestive system. Those are all smooth muscles that cannot be controlled voluntarily. Okay, so it's called the bronchial tree, and you could tell why it's a tree. It starts looking like a bunch of branches, but as it gets deeper and deeper, it gets replaced with smooth muscle. Here are a sample of your lungs, and we saw that, and we saw the lung tissue, and you could see how the lung tissue is also segmented. We discussed in laboratory that the lung tissue is segmented as also a further protection function, so that if one part of the lung is damaged, the other parts can pretty much handle it. This area here is called the hilum. Sound familiar, right? Just like the kidney, that little indentation in both lungs has pulmonary arteries, pulmonary veins, and a main stem bronchus that goes through there. Or in this particular case, a lobar bronchi. But just know a bronchus, or the offshoot from the trachea, goes in the hilum. So again, beautiful, all the above. You have an apex, and you have a diaphragmatic surface or diaphragmatic base. Remember, the diaphragm is a muscle that controls, helps you control your breathing. Okay, you will notice there's a little cardiac impression on the left side because your heart is on the left side. So what distinguishes the left from the right? The left has a cardiac impression. Okay. Both lungs are also covered with a covering, just like your heart, just like your pericardium, right? It's called pleura, and of course it has a visceral and parietal layer. The visceral layer is the guts layer, the parietal layer is the tougher outer layer. And just like the heart, it's separated by a space with a very, very tiny space, and it has some fluid in it, and its function is not only protection, it's for lubrication of the lungs. Because all day, every day, your lungs are expanding, contracting, expanding, contracting. Okay, let me check how good am I on time. Pretty good. Okay, so we already talked about smooth muscles. Who has more smooth muscle? And I'm looking at item 5 in our notes. Bronchioles over trachea. Remember, the deeper you go, right, main stem bronchus, bronchiole are the tiny, tiny branches, and we're going to go into these tiny branches. So as the deeper you go into the lungs, there'll be less and less cartilage and more smooth muscle. We already talked about the significance of the lung lobes. Look up yourself. You can even see yourself who has who has 2 lobes, who has 3, who has the cardiac impression or cardiac notch. Hilum, we already talked about the hilum. Difference between external and internal respiration, we discussed that at the beginning of this lecture. External respiration is the gas exchange between your lungs and the outside world. Internal respiration is the gas exchange between your bronchioles, right? And we're going to talk about that in a minute. And your capillaries within the lungs. And remember, gas exchange must occur in a semi-moist environment and in a very, very thin wall like your capillaries. Remember your arteries and veins? Arteries go away from the heart, veins go back towards the heart. There has to be something that connects the two, and the thinnest wall blood vessel is called your capillary, and the capillaries connect arteries and veins. And it makes sense. When the artery, right, the pulmonary artery, which is deoxygenated, needs to pick up something, it's going to go and be a capillary. It'll pick up oxygen, and then what? Then it'll go into a pulmonary vein, and then the pulmonary vein goes back to the heart via the left atrium. Remember, put it all together. So remember, if I ask you about oxygenation, pulmonary artery versus pulmonary vein, you'll notice that it's backwards. And you can see from this picture right here, the pulmonary arteries are colored what? Blue, because they're deoxygenated. The pulmonary veins are colored red, because they are oxygenated. If I have these pictures on your final exam, they will be in color. Okay, now let's talk about the muscles required for breathing and what is called quiet breathing. Normally, when you're breathing normally and just sitting there in the table, breathing is quiet, and it also doesn't require any effort. It's automatic. But of course, you start running around the house, you'll start breathing heavier, and then it's not so quiet. And another thing is that you can control your breathing. Right? I can inhale, I can exhale, I can hold my breath. But in normal breathing, I don't. Now, look at the terminal bronchiole. Remember, the bronchus turns into bronchiole, small. At the end of the terminal bronchiole, terminal means it's the very end. That's where we have functional units called pulmonary alveoli. Alveoli, I think is Latin or Greek, I forgot which, but it means grapes. And if you look at it, it looks like a whole bunch of grapes. So that is where gas exchange is going to occur between those grapes and those capillaries you see here. And you see the capillaries here? They turn from what? They turn from blue to red. So you have this pulmonary arteriole, right? Going away from the heart. Then there's blue, then it picks up some oxygen, and then it turns what? It turns red. And you can see you want the thinnest membrane or the thinnest wall possible, so that oxygen can go in the body and then into a red blood cell. Then carbon dioxide can do what? The carbon dioxide from the red blood cell can go back out, and that's what we exhale. Okay? Let me look at the muscles of breathing. And again, I do apologize if I'm going a little bit fast, but I'm trying to fit it within the context of the video. We just talked about this earlier, dust cells. I didn't call them dust cells, but I remember I mentioned macrophages. We looked at that during the blood, when we talked about blood. Macro meaning large, phage or phage meaning to eat. So remember one of the thugs in our immune system? Macrophage. They don't think too much. They are also in our lungs, called dust cells. they deal with the stuff that's in your dust, the dust that and the debris that accidentally get into your lungs. Okay? We talked about the respiratory membrane. We talked about its reduction of friction. Another thing, and we already talked about compartmentalization, meaning you'll see there's these little rooms, and your body likes to organize things in little rooms so that if there's something bad going on in one room, your body can try to contain it, and that's what that's the function of compartmentalization. Now, the next thing we're going to be talking about is this pressure gradient on how you breathe and how you use your muscles for breathing. Okay. See if I can. Now, of course, you're breathing usually it's automatic. It has respiratory centers in your brain. There are chemoreceptors and stretch receptors. The chemoreceptors measure the amount of pH, measure the amount of oxygen. Now, I just want to get it out there that it isn't really oxygen that your body senses when regarding your breathing. You know, we were raised to think, oxygen is really, really crucial. In actuality, the main chemoreceptors, or the main receptor that picks up the chemical is not oxygen that the body is concerned about. It's concerned the carbon dioxide level, which is reflective of the pH blood level, because you remember they're all related. Okay? I'm trying to get to how you breathe. Pressure, resistance, airflow. No. Okay. Here you go. You got to think about your body, or your thoracic cage, or your chest area. Remember, your thoracic cavity. Kind of like a bucket handle. If you look there, now, another concept before we look at this diagram is that air or anything in this world has to have a pressure gradient for it to naturally flow. And the pressure gradient goes like this. Right? Pressure or air is always flowing. And same thing with water or anything. Anything is always flowing from an area of high concentration to an area of low concentration. So let's think about it. Let's take, for example, you're at Macy's and you're at the perfume counter, and I, puff off a couple of sprays. Right? Within the immediate area, it's going to be highly concentrated. But then after a while, what is that high concentration going to do? It's going to dissipate, it's going to move to what? An area of low concentration. So it's going to start to do what? Spread out. So gases like oxygen, like carbon dioxide, like moving from an area of high concentration to low concentration. So let's look at this diagram right here. So when we start off, when there's no airflow, there's a moment at rest. For a brief moment, the pressure of your lungs equals the pressure, or atmospheric pressure, or the pressure out. Now, if the pressure outside equals the pressure inside, that means you're not breathing. Okay? That is a really beautiful question. The atmospheric pressure equals the internal intrapleural pressure of your lungs. If it equals it, guess what? You're not breathing. Okay? But what will I do when I start to breathe and I pull the bucket handle up, right? I pull the bucket handle up and out, and when you inspire, you notice, what do you notice? Your diaphragm flattens out, goes down, and then it does what? It forms like a vacuum. So now, it forces a negative pressure on the inside of your lungs. And remember, things like going from a positive to a higher number to a lower number, or higher pressure to a lower pressure. So if my diaphragm starts pulling down, kind of like a plunger on a syringe, then guess what? Where's air going to go? it's going to go in. So then I'm going to have inspiration. And then, of course, when the pressure gets so great on the inside of my lungs, that means the pressure will be greater on the inside of my lungs than the outside pressure. Then guess what? The exact opposite will happen. Expiration. So how could I ask this question? I could ask you, if the atmospheric pressure equals the intrapleural pressure, guess what? You are at rest. You are not breathing. If the intrapleural pressure is more negative, or the internal pressure of your lungs is more negative than the outside, guess what? You are inspiring. And think about it. I pull my diaphragm down, my chest will open up, just like that handle, and it'll move out and up. Watch how you breathe. Your chest will move out and up, and that's inspiration. And of course, when the pressure in your lungs gets so great, the exact opposite will happen. Then you will do what? Exhale. All right? And that is pretty much the worst I could do to you. Let's look positive. Well, that's the best I could do for you. Let's be positive this 2015. Okay, with that said, that is the conclusion of your respiratory system. And good luck on next week's exam. And thank you. Get to be a female. Now, how do you get these chromosomes? You get one from mommy and one from dad.